Okay. Can we have the screen share starting? Okay, cool. Great. So we will start with this screen, Vishu. We have 30 seconds more. Let's, I think we're already live, is it? Yes, okay, yeah, I think yes, we are. Yes, we're going to start, okay. Good evening to one and all who have come here. Thank you so much for joining in with us today. This is the World Mental Health Week, and this is something that we are very happy that you have taken out your time to come and learn more about getting into private psychiatry, about the early career psychiatrist's journey into private practice. And we're very fortunate to have some great panelists here. Chiefly, we have Dr. Alok Sareen, who's a very accomplished psychiatrist from New Delhi, and someone I can hold in very high esteem and regard. He's inspired me on my thesis and my journey in advanced directives and autonomy and decision making for patients. So aside from all of these things, there are many laurels that he has. He's also author of one of the famous volumes of the effects of partition on mental health in India. Aside from that, he's also a Tinmurti Fellow and works in Sitaram Bhartiya Hospital in New Delhi. We have with us also Dr. Jitendra Jhakar, who has been my colleague and in NIMHANS and is now also practicing in Delhi. He will also be talking to us about a very relevant topic, which we will introduce. And finally, but nowhere in the least, we have Dr. Vandana Shetty, who has been in the private psychiatry field for some time now, and she's also someone who specializes in the recovery and promoting the recovery journeys of patients. So we've got a really great panel who are going to give you an all-round view of what all can be incorporated into private practice and how best to go about it. This is just the second chapter in our series. A brief about the series was that this has started off as a fallout of the COVID-19 pandemic as job opportunities for psychiatrists, especially those coming out with their post-graduation, be it MD, DNB, DPM. All of them have been on the down low, and it's been something that more and more have been pressed into taking up some sort of private practice, either on the side or at least, if not full-time, at least part-time. Now, we'd like to support our early career colleagues all over the country in this journey, and we'd like to see that all the learnings from the seniors are passed on, as well as we can connect, collaborate, and overcome whatever the inequities are. And the sharing of knowledge will definitely lead to better practice and better quality of care being delivered across the board. Brief about us: we are the Indian Association of Psychiatry Trainees. We launched on World Mental Health World Mental Health Day last year, and this was in the middle of the pandemic, as we saw the impact of the pandemic on psychiatry training and early career psychiatry. We have in our motto to connect and collaborate with all the Indian psychiatry trainees and the early career psychiatrists so that they can overcome whatever inequities they face. Now, that's our website over there. That's www.iapt.in. It's fairly a fairly new website. I mean, it's our we're still developing, working on it, but you can find a lot of stuff about us, about connecting with us, about following us, and looking out for the events, and as well as membership with us. Our membership is a subscription model. We use it just to be able to finance the events that are being done. We are a not-for-profit, and we are completely open about all the events that we do, and we would like more of the early career colleagues and trainees to come on board and make this a truly by the trainees, for the trainees, by the early career psychiatrists, for the early career psychiatrists initiative. Brief about the housekeeping rules. While during the speakers' presentations and their segments, please do keep yourself on mute. It's very easy to inadvertently go unmuted, so do be careful about that. We wish that if you have a question, you can always put it on the chat box. You can also raise your hand. We'll come there. There's going to be a moderated Q&A at the end. We are really happy for you to be here and partner with us in this journey. Thank you so much. Now, I'm just going to hand it over to Dr. Alok Sareen. And sir, please go ahead, and thank you so much for agreeing to be with us here today.
Thanks. Good evening, and thank you, Dr. Sharad, for inviting me to speak here. And thank you to the Indian Association of Psychiatric Trainees. I am delighted to be here. A disclaimer. Firstly, what I am going to say may not be exactly what the psychiatric trainee is perhaps looking for, because it's not going to be tips about private practice. It's not going to be tips about how to succeed in private practice. It's going to be more general. So if you think that it doesn't make sense, the best thing is to just ignore it. But anyway, since I am going to speak, today I'm going to speak on the practice of psychiatry. And on the face of it, it's a rather ambitious subject. In my defense, however, the original subject of the talk, which I was supposed to speak on, was cultivating respect and building a successful practice, and the importance of having a strong guiding ethical code in practice. And you will agree that that is perhaps even more ambitious. Either way, what has happened is that the organizers of the Indian Association of Psychiatric Trainees have successfully signed all of you up into being a captive audience to hearing my thoughts. So let me just go ahead. This is it's a rather large subject, and we can go on endlessly, but we don't have endless amounts of time. So I'm going to restrict myself to 4 or 5 points. The first point that I would like to make, and this may be a little provocative, and that is this, that I think that there is no real difference between the practice of psychiatry in the private setup and in what is called the governmental setup. I'm not sure that everybody agrees with me. I'm not sure that everybody would agree with me. But I think that this actually is true, that there is really no difference between the way that psychiatry is practiced in any of these setups. So for the purpose of argument, let us, for the moment, take two setups. And let me take two setups which I am familiar with. Let us take the setup of the private clinic or the private hospital. And let us take the setup of, let me say, the teaching hospital, the All India Institute of Medical Sciences, the AIIMS model, or let us say the National Institute of Mental Health and Neurosciences, the NIMHANS model. Now, in either the AIMS or the NIMHANS model or the clinic, the private clinic model, what exactly is the difference? Some will argue that there is another third model, which is the corporate hospital model, but let us leave that aside for the moment. When you or I am sitting with a client.
Pardon me, sir. I am sorry to interrupt you. There's a request for you to be a little bit louder, sir, in the chat.
Okay.
Yes,
I'm so sorry.
Yes, sir. So if you could come closer to the mic, that would be
Is this
solved by support.
Could I put on my headphones again? Will that
just a second, sir. Let me just ask. Dr. Partha? Dr. Partha, can you please tell if this is
yes.
right?
Yeah. Could you try once again? Sir, I'm not able to hear you. Yeah, it's better.
Dr. Sarin? Sir, can we continue, sir?
We can't hear you, sir.
So I think there's no mic on that.
Yeah. Is that clearer now?
Yeah, this is better, Dr.
Okay.
Pratha?
Okay.
Yes, sir.
Yes.
Better.
Thank you.
So essentially, when you or I am sitting in the clinic with a client, or as the new nomenclature goes, with the service user, what matters is how I or you treat that person, how gently or sensitively I listen to him or her, and how respectful I am of him or her. And that perhaps is all that really matters. As it happens in many ways, I think that perhaps actually in practice, the doctor is often more respectful, more sensitive than would be the situation in many, many government hospitals. But we also know that there is no generalization that is true in any case. As freshly minted psychiatrists, as people who have been trainees till recently, I'm sure you've seen many consultants, and you've noticed very, very many different styles of functioning. There are consultants who are technically sound. There are consultants who are extremely knowledgeable about medications. There are consultants who are very good teachers. And then there are the consultants who are actually kind, gentle, and sensitive towards their patients. These few, the all-rounders, as it were, are the people who actually become the role models for many people. For the psychiatrist, for the clinician, and let's forget psychiatrist, for the mental health professional, I think the biggest learning is perhaps the recognition of the fact that the most important person in the room, in the clinic, is actually the client. And if we are able to learn that, then the effectiveness of the mental health professional actually increases generationally. In practice, as in the hospital, there will be many people, and especially the, as we all know, the more senior one gets, the often we forget that this basic fact as to who is the most important person in that particular room. And it's as likely to happen in the academic setting as it is likely to happen in the practice setting. Which brings me to my second point, the academic bit. Very often we think that there is a very sharp divide, that the practice of psychiatry is all about making money, and working at the AIIMS, NIMHANS sort of place is all about patient care, about service, and it's about academics. And actually, nothing is, to my mind, further from the truth. The fact of the matter is that the limitations that all of these places place on us in many ways is as much as we let them. And speaking from personal experience, I know that, that there hasn't actually been very much limitation in any of the things that, for example, I would have liked to do. Speaking again for myself, given my interests and given my peculiar sort of need for, how should I say, independence and my personal peculiarities, practice has actually worked quite well. Academic writing has happened. My interest in community mental health has happened. My association with various policy making processes has happened. What I think of as the interdisciplinary research has happened. And I think that in many, many ways, as much, it depends actually upon us. We can do as much as we would like to do. And the scenario itself doesn't impose that much limitation. It imposes about as much limitation as I think we let it. In the clinic, I think the first thing that one learns is perhaps to look beyond the disorder. So when somebody walks into the room, it's not a schizophrenic or a depressive who's walking into the room. It is a person with schizophrenia or depression. And until I start seeing the person for who he or she is, my approach is always going to be extremely limited. The person is not a unidimensional, monochromatic construct. She can and will be very many different things or personas. And the better I know her, the more effective I am going to be. And I always think that one way of perhaps trying to understand this is to switch the lens around a little bit. Let's stop thinking about the client or the patient for the moment. How do I think of self? How do I think of myself? Let me tell you how do I think of myself? Do I think of myself as a clinician? Do I think of myself as a researcher of archival history? Do I think of myself as somebody who's deeply interested in let us say, advanced directives, as Sharad has just pointed out? Do I think of myself as an advocate of community mental health? Do I think of myself as a motorcycle enthusiast? Do I think of myself as a lapsed player of golf? And the fact is that I think of myself as all of these things. I think of myself as wearing all of these very, very many different hats, and I am able to traverse and inhabit all those different personas at different times. And essentially, this is true not only for me, this is true for all people. And unless I start thinking of the person who comes into my room as being larger than just the disorder that he is experiencing at that point of time, my effectiveness is going to be very, very small. I'm not going to take very much time, but allow me to digress for a moment. And, Sharad has already referred to the pandemic. So how could we not talk about the pandemic? So in talking about the pandemic, there is a gentleman called John M. Barry, who's written a wonderful book, a magisterial book, which is called The Great Influenza, which is about the pandemic of 1918. And as you might know, one of the interests that I have is about the history of psychiatry. So somebody in an interview recently in 2020, somebody asked him, what is the biggest learning that there is that you have about the 1918 pandemic? So he said, look, quite apart from all the other obvious things, things like public health care is very important, and all this hygiene and sanitation are very important. All of that is standard stuff. The most interesting thing that he said was, what makes the difference between success and failure is to tell the truth. If there is one learning that we have, it is to tell the truth. Governments which tell the truth will not prevent disaster, will not prevent death or disorder, but what it does is it maintains social cohesion. It helps individuals, it helps societies, and it helps build resilience. And if you think about it a little bit, this is perhaps as much of a blueprint of recovery for society as it is for the individual. So I've been thinking a lot about this, and I think one of the first tenets of practice, regardless of where you're practicing, the first tenet of practice should be tell the truth. Tell the truth, because if I tell the truth, it will not wipe out illness. It will not cut it short. It will not deny suffering, but it will make the dark world that much more bearable. If I am able to digress a little bit more, my friend and colleague, Sanjeev Jain, my partner in crime, as I am very fond of calling him, and I have been doing, we've been fascinated by the history of the mental hospitals in India. And one of the most fascinating mental hospitals, or the most fascinating periods of this time, is the mental hospitals of Ranchi. But anyway, that's a different story. In 1936, there is this superintendent of the mental hospital called Dr. Dhunjiboy, Major and then later Colonel Major Jal Dhunjiboy, who is the superintendent of Ranchi Mental Hospital, the Indian mental hospital in Ranchi. Ranchi, as you know, had two then, it has two now, it had two then as well. So the superintendent of the Indian mental hospital is Colonel Dhunjiboy. In 1936, which is 90 years ago, in the annual report of the mental hospital, he is writing, in the mental disorder, it is the patient himself who is being treated and not so much other parts of the body. And that is why the personal factor is so important. It is essential to try and see the world as the patient sees it, to accept for the time being, the reality of his experience, and to stand alongside him in his difficulties. This writing is 90 years later, luminescent in its characteristic. It shines out of the paper those thoughts can light our way today. This is the quintessential ethic of practice, to stand alongside the person in his difficulty. And I think that in many ways, what Dhunji Boy articulated almost a century ago holds true today, has held true then, and perhaps is going to hold true forever. What is honesty in language? What is authenticity in therapy? What is empathy in real life is perhaps what we can think of as the ethic of practice. This compelling paragraph seems to capture in a very few words much of the essence of the principles of caring and compassion that biomedicine, I think, has frequently been accused of having lost sight of. And I think that that is something that we have to remember. The last point that I would like to make, the second last actually, is what I think of as the philosophy of practice. I think we owe it both to our client and perhaps much more to ourselves to ponder a little bit about how we offer help. Mental disorders are often scary, very frequently anxiety-provoking, very commonly chronic, very disruptive of life, of functioning, of families. They're often layered by personality characteristics which influence both the presentation of the disorder and the outcome of the disorder. And this often is in the backdrop of families which have the same characteristic in big and small ways. In the real world, how on earth is one even supposed to make sense of this? If there is one way that we can think of, apart from honesty, I think it is perhaps respect. I think that maybe we need to think about the question that we should treat the person who is sitting in front of us as we would wish to be treated, with sensitivity and with respect. Let us not think that our tools are the end of all things. Our tools are good, but like us, our tools are limited. It is the use of the tool that matters. It would be hubris to think that prescribing a capsule of fluoxetine or a tablet of clozapine is all that is required. I actually need the humility also to stand by the individual. I need to understand him. I need to stand by him. I'm not for a moment suggesting that technical competence is not necessary. Of course it is. We certainly need to know how to use the tool. There can be no reason, absolutely no reason, to be ignorant of medication, of the side effects of medication, of the interactions between medications, of the nature of the disorder. Medical competence is where we have to start. There can be no doubt about this. But medical competence, in a very real sense, is perhaps only the beginning. From there, I think perhaps we have to start with learning how to stand by the individual. From that, with respect and gentleness, we start using the tool of competence. And then in whichever scenario we work, whichever practice we form, whichever the locale is, whether it is at NIMHANS or whether it is in a private clinic somewhere, then we don't actually have to cultivate respect. In my opinion, respect is actually never cultivated. It's earned. And it is the paying of respect which in turn earns the respect that I get. I think that's perhaps what I would like to say I'm sorry if I sound pontificating. I'm sorry if I sound, a little serious. And I'm sorry that I don't have any, as I said, 4-point tips about private practice. But I think that practice anywhere is exactly the same. And that perhaps if we go with that, it might actually work. So thank you very much for your patience. And I'm delighted, as I said, to be here and talking to you. Thank you.
Wow, sir. Thank you. Thank you so much, sir. I think your words definitely were so true. It rings very, very, relevant at this point of time. That truth does make a dark world more bearable and a dark reality more bearable, sir. And I really hope that these words have seared our conscience with regard to private practice and really, been a wake-up call with regard to exactly what we are expecting within private psychiatry. I'm sure that people will have, all in attendance will have lots of queries to ask you and some scenarios which they have found difficult to deal with, and especially when discussing about the truths, the white truths, the half truths, the white lies, and the half truths and all of those things. Next up, sir, I would like to introduce to everyone Dr. Jitendra Jhakar. He is my colleague from NIMHANS itself, who is now working alongside Dr. Sareen in Delhi itself. And he has also been practicing in private right now. He has a very interesting topic that he's prepared for all of us. It's a review of all the platforms that he has been using to reach out to clients and get appointments and work with them. Aside from them, he will be sharing some of his journey as how he transitioned into private psychiatry during this COVID time. When leaving a plush government job is not something which was very advisable, he went against the flow and did that. And let's hear from him about that. Over to you, Dr. Jhakar. Thank you so much for agreeing to be here.
Yeah, thank you, sir. So I'll be sharing my slides. So it's not about a theoretical class. I'll be talking very practical thing. I think so the things which basically most of us have doubts when we are on the verge of deciding whether we'll have private practice or we'll end up into a government setup. So before I start, few disclaimer. My slides are visible? Hello?
Not yet, not yet.
Okay. I share.
Dr. Jhakar, your slides have not come up.
1 minute. Just 1 minute. I'm sorry for just 2 minutes.
If you could also just send us a copy so that we can also kind of put it up and see.
Okay, just 2 minutes. Sorry for the disturbance. I don't know why.
That's all right. That's all right.
Okay, otherwise I'll start without slides.
Yeah. Could you also share them with us? So once we are able to put them up, we'll show them then.
Okay.
Right. If you prepared the slides, we'd like you to also have them. Give us a few minutes after that. So you can continue and we will put it on.
Yeah. Sharad, I have shared with you.
Sure.
Okay. Sorry for the disturbance. Anyway, I will start. There's nothing much in the slides. So before I start, the few disclaimers is that whatever I'm going to talk about is about my very personal experiences. what I learned in my maybe the initial course of my journey, maybe I'll say in last 3 to 6 months. So this is not about success story that I'm doing very well in my life with regard to my professional thing. This is neither a failure of story that I am not doing good with regard to my professional things. This is more about my story of struggle. Ki, what I learned over a course of time in maybe in the initial early phase of my career. So I'll talk about the few things which I personally have gone through, which personally I struggled. Is first about that key, which way should I go ahead? Whether I should go ahead with a private setup or should I go ahead with a government thing? So this is the thing I think so most of us, once we finish our SRCP or once we finished our MD, we normally come across. So the very genuine and very frank answer which I asked myself is that key, what is my goal for next 2 years or 3 years down the line? So I had a very frank answer that maybe I want more financial stability. Second, that maybe I want to own my own rights. What time basically I have to go and see patient, what time I have to be free. So I should have right to freedom of my practice. So thinking that way, I went ahead with the private. Second is that when to start and where to start. So when I was doing my SRCP in Niemans, I thought that if I have to go to my native place is New Delhi and Haryana. So I thought preferably opting out and continuing my SRC last year of SRC from Delhi, where basically I get used to the patients, where I'll get used to the things around. I'll connect with few people around. So finally getting a whereabouts and getting some vibes about the place where I'm going to start my clinical practice. The third thing is basically whom to contact. And this is the things which basically most of us we find it difficult, that even if I want to open my private, you are very naive to it. And you find sometimes very helpless and you find sometimes that goalless. What should I do? So what I have gone through is basically I discussed with two to three seniors who were seniors in my psychiatry. Like one of them is Dr. Alok Sarinoli, and he guided me very well that what basically which approach should I go, how should I open my psychiatry, whether I should open clinic or whether I should go and liaise with few hospital around. So they will guide you, and at least they being in the field for so many years, you will get a very genuine experience from them. Third thing is basically how to find vacancy. I decided that okay, I have to start my private practice. Then where should I start? And which hospital should I go and talk about? So what I have done that I stay in Rohini in New Delhi. So I went to 4 or 5 hospital around and whom to contact. That is also basically a question of interest. So many people suggested that you go and talk to HR. But I personally felt very uneasy to go and talk to the HR. I thought that maybe talking to the medical superintendent or a person who is of medical background, that would be a nice option. So when I approached 2 3 hospitals near to my place, I told them that I want to work as a consultant psychiatrist. And they, I think so. If they have vacancy, normally they come and they will ask, okay, you can join. But this way of finding the vacancy, until unless you don't have a guidance or until unless you don't struggle, because you might have to go to the multiple hospitals, and sometimes you'll get an option, sometimes you feel that this place is already been occupied. But what I understood that you have to keep on trying until unless you are not satisfied with 1 or 2 places where you have a good space of patient. Third is that key, even if I've decided, okay, I have to go ahead with the private thing and I'll attach myself to the local hospitals, then how to build up network, how people will know that you are working in this area, because you are not so popular, you are not so famous. So you have to, these are the very practical thing which I experienced. So I thought I'll share my personal experiences. So what I have gone through is that basically I met few of the seniors from my UG college, my MBBS graduate, who are basically working in different fields, who have in different branches. I go and I approach them, said I started working, so kindly refer patients to me. And being from the same institute, being from the same undergraduate, this thing, most of the seniors are very much accommodative. So I get, I think so, 5-6 referrals every month from either one of my seniors, either 2 of my seniors. So this basically, I felt it, this is a very good source of patients inflow. Now the third, maybe other questions come to that even if you have attached to a hospital, then what should be our sharing option? Like whether I'll get a fixed salary or whether I'll go for a percentage basis. So in most of the hospital in Delhi, if you'll ask, I think so, whatever I had experienced is that the ratio is around 80 to 20%. And none, I think, so very rare number of hospitals have a very fixed salary. So most of the hospitals, it's like you come and see your patients, and you will get either 70% or 80% of that. In the bigger corporate, normally the percentage is 70%. In the shorter or more local, it's around 80 to 85%. Then how much should I charge? Because most of the consultants, most of the psychiatrists who are already been established in the branch, and they are charging mostly 1,000, 1,500 to 2,000. So at what fees I should start my practices? So what I thought that I'll start with my minimum 1,000 rupees. And but the difficult thing, which is basically we felt that if you charge 1,000 rupees, and in what these are the very clinical thing, that if the patient comes in a follow-up and you have done 2 3 consultation and patient is not improving, this is basically anxiety provoking. You start questioning yourself that why patient is not getting better, is you are doing something right, or is only the due course of the illness. So once you start charging, in the government setup is different, but in the private setup, once you start charging from the patient, then the onus of responsibility also fall on you. Then next question, basically, with the confusion which I've gone through, should I do therapy by myself or should I refer? So what trend which basically I followed is that and which I felt it very rewarding is that I think so you choose 2 to 3 patients for yourself, and if you have 3 to 4 sessions or 5 to 6 sessions in a month, one, that you will get financially more source. Second, that you will also learn in the therapy. So I personally felt maybe if you have 5 to 6 sessions by yourself, it is more rewarding, and it helps you to build up both financially, and as well as it will basically help you to gain how patients improve over a period of time. And the last question, which is still unanswered for me, that when to open my own clinic. I'm still attached to 2 to 3 places, but the last question, I think, which I still need to be explored, is that, and I'm still stuck in this phase when I have to open my own clinic. So now coming to the second part of the presentation, that this was about my few doubts which I had, few struggles which I experienced during the early course of my psychiatry. And the second maybe few minutes of discussion will be about the exploring online platform. So there have been few, I think specifically during the time of COVID pandemic, the online platforms have really explored, and I think so many corporate setup have come with online consultation. So first and foremost, which I enrolled myself, is the Practo, and I think so all of us are very much well aware about Practo. So in order to enroll the Practo, you have to have your own physical space. So because they will come and they'll verify your place, you have to give your address. And second is that it's not only basically, or not only for the psychiatry, it's also for the other branches. The problem comes is that for each consultation, each patient who basically steps into your clinic through Practo, they charges around 325 rupees in Delhi. So that amount of money you have to give just only for the inflow of patients. Second platform is basically Talk to Angel, which I have enrolled, and this platform is basically only for mental health professionals. So they have a group of psychiatrists and psychologists, and you can have your own fees in this platform, and the share is mostly 70% and 30%. So for each consultation, and normally you can get around 5 to 6 consultation over a period of 1 month, and for each consultation you will get your share. The third platform is Doc Vita. So this platform is basically recently have been launched, I think, from last 5 to 6 months. So they also have the same, only the group of psychiatrists, dermatologists, and 2-3 other branches, and where you get an inflow of around 3 to 4 patients per month, and it's the same 70 to 30% ratio. The other platform is the Tata Health. As we all know, that Tata Health itself has a very good name, and they have very good inflow patient. In fact, most of my patients I am getting to this Tata Health only. You have to enroll yourself. So they have 2 ways of booking appointment. One is through InstaDoc, and second through is they can directly come and they can register in your online profile. In both way, you can in your profile you can keep your own fees, and through InstaDoc, they have fixed share that they have kept 600 rupees for the psychiatrist, so you'll get 80-20 out of it. And the last is MFine, which I just enrolled myself. They also have the same 30 to 70% of sharing, and they have, apart from psychiatrists, they have other group of professionals also. Few other platforms which I think so need to be explored and which are available online is Bajaj Finance Reserve Health. They suddenly started, they started recruiting health professional. Apart from that, curfew.com, Dr. Liberate, DocSap.in, and Dr.Medicbuddy. So these are the other platforms which you can enroll yourself. And all these platforms gives some inflow of patients into your OPD. So, and in fact, if you will ask me, the 20% of 20 to 30% of my monthly income I generate through this online platform. And not only about the financial help, also they increase your digital presence. So they help you to get connected to the people, because once you enter into private practice, people come and they basically browse you on the internet. So being available in most of the online platform increase your digital presence, and they help you to build up your private practice. So I end up here. Thank you. And sorry, I think so I was unable to share my slide.
No problems, Dr. Zakir. That was still a very lucid and a very great explanation for a lot of people to know about what platforms mean and how they can really help. I really like what you meant about increasing the digital presence and being available for people to review you or browse you, or as other commodities would have it, window shop for a psychiatrist as you. Thank you so much for being here and sharing with us. Dr. Vandana Shetty is our next speaker and panelist. She's also a colleague from NIMHANS. She finished her studies from JJ, I'm sorry, I'm not sure. I'm getting the college.
That's right, JJM.
Yeah, JJM College in Davangere, and then came to NIMHANS for doing a fellowship in psychiatric rehabilitation, mental health rehabilitation. And she's really interested in building up the private practitioners in India towards helping patients with their recovery journeys towards the functional recovery, beyond the clinical remission itself. And I'm not going to take more time from her, and I hand over all of the next segment to you, Dr. Vandana. Thank you so much for being here.
Thank you so much, Sharath. It's wonderful to be sharing this platform and be here to share my experiences. I completely agree with Dr. Saran's experiences that he was able to share with us. And now that I'm into the real world practice, I can connect very well with those experiences. And even Dr. Jakar's tips on how to establish your private practice. So I will be talking about how to integrate functional recovery. This is something that's very close to my heart, and I was fortunate to also get some additional training in this area before starting off. So I will just share my screen just a minute. I hope you guys are able to see this. Right. So you can see the slides, right?
Yes, we can.
Yeah.
We can.
All
it's
right.
Wonderfully clear.
So I would like to mention that my experiences come from an urban setting. I practice in Bangalore, and it's predominantly an OPD-based hybrid model of practice right now because of COVID, where we do both online and offline work. So it may be more relevant for urban settings, but it definitely is going to be something which is adaptable even to practice in suburban areas and rural settings. Because the one core principle that is important for functional recovery is that it has to be patient-centered. And that is something I think we can adapt to different settings. Now, one of the important things about recovery is that what we look at as recovery as clinicians is completely different from what patients perceive as recovery, right? Because of course we come from a medical model, and for us what's important is that there's symptom reduction, and clinically the patient is doing better, even if it comes at the cost of some side effects. Um, we would consider it as a good bargain. But for patients, it may not be the same depending on what part of life they're in and what is relevant to them at that time. It could mean something entirely different. So the quality of life as defined by the patient could be entirely different. It could be about dealing with stigma or going through what are the expected goals for the age of the patient. And unless we are able to align our goals with the patient goals, there will be a big disconnect, and which will come in the way of recovery, which is probably what Dr. Sarin was also talking about earlier, about how it's important to see the patient as one person with an illness. And it's also an important goal of recovery. So if we look at it from the patient perspective, you would hear different things what are important to them, which we may not generally take into account in our routine practice, which would be simple things like just getting back to how they were before the illness, reconnecting socially, whether it be with friends or family, or finding a companion to marry, or if married, being able to establish all the roles that would be important as a spouse, etc. Or it could be about financial independence, either completing education or completing or being able to be meaningfully employed, or being able to generate as much income as they were able to before the illness began. Right? So these are generally aspects which are important to patients, which we may not really take into account when we are deciding treatment factors. So it's very important that as a part of managing a patient, whether it is in private practice or in an academic institute, we consider functional recovery as a recovery of the patient as a whole, not just from the treatment aspect. And this is something that should begin right from the first visit of the patient. Some of the key questions which could lead us in this direction are just asking the patient, what is it that the patient is expecting from this treatment? What is it that they are expecting to set out as goals, right? Now, functional recovery is something that has to be customized to the person who we are treating. And in India and in Asian countries generally, I guess it's common to have the family also together. And sometimes there might be a mismatch between what the patient wants and what the family wants. For us, what should take priority is what the patient wants. And if possible, we should try to integrate what the family also conceives as goals. But if it isn't matching with what our client wants, I think that the priority should go to what the patient wishes for. And in this regard, one of the important things is about teamwork. In private settings, it's difficult compared to an academic institute, because unlike other bigger setups, we wouldn't have a large team with a psychologist, social worker, a nursing team, etc. Right? But one of the key things that I found to be very helpful is developing a network. Even more so important once we move into private practice, that we connect with other psychiatrists in our area, connect with psychologists, and connect with social workers, and use that team, build your own team and build your network. And whenever the need arises, you connect people to the right resources, right? And this improves the trust factor that the patient has with you. It improves your own work. And it's, I think once you move into private, one of the key things that I found missing is that team feeling. Because when you're in a college or in a medical setup, you always have a senior or a colleague to look up to and share experiences with, which is something which really comes missing in private practice. This is a gap that can be filled once you create your own team of people, right? Like they could be working in different settings, but you could collaborate with each other for work. And if this isn't possible, if building a team isn't possible, then of course it comes upon us to be playing these different roles in different settings. And that is why I would describe a plan for functional recovery as a mutual learning, because the patient may benefit from us, but we also benefit from the patient by learning different ways in which we come towards a common goal. For all of this, what it would really take is maybe a few additional minutes of time It may take like another 10-15 minutes of your OPD time. It might be difficult in every sitting, but what would really matter is the intent of planning a functional recovery. And this is something that we will be able to integrate. Sometimes it may not be possible that we have a solution right in hand during the first visit. But a lot of times my experience has been that if I was able to share with the patient that I'm really keen to help them move towards recovery, but at the moment I don't have a solution, I'll come back with something when I figured it out. It has been very reassuring for the patient, and they have made sure to put in the efforts from their end, and both of us collaboratively have been able to come to a solution which has made a difference to the patient's life. So the intent, I would say, is something that is at the core of planning a recovery model of treatment. This, of course, is something that will not just establish rapport with the patient, but the patient itself would feel validated, because most patients will tell you that the experience when they visit a hospital has been that they are looked at as the diagnosis. So if a person has depression, then the label, once it's on them, then after that, as a person, they're not heard or validated. So when we go a little beyond the diagnosis, try and understand what are the challenges they're facing, or what are the ways in which we could help them come back to a near normal life, that in itself can be very validating for the patient. And for this, what is really important is that we plan long term right from the beginning. So the general idea of a recovery-based practice is that it is meaningful only for people who have chronic illnesses or who haven't improved despite treatment. But this may not be true, because let's say a person comes to us with anxiety or depression, right? Like anxiety being one of the more treatable conditions, we would say, if it's mild to moderate. Even then, this person would be having a lot of difficulties in social settings or with regards to education or employment, which may go unnoticed. So definitely using medications to relieve of symptoms is important, but it's not the only thing that would help. It's also important to set realistic goals that will help this person come back to normal. And that's why the integration is so important. Now, one of the challenges I think that comes up in setups in India and is that not only are we resource deficit, we do of course have a very skewed ratio of mental health professionals for the number of service users, but also that I think in most medical colleges, there isn't any good exposure to a rehab-based model of care. Most of us in most medical colleges are only focused on acute care, and we would either lose the patient once they become chronic, or that isn't the priority. So most of us don't have that experience to manage chronic illnesses. And there is also a false notion among medical professionals, among psychiatrists, that rehab is only either meant for people with a poor prognosis, or that it is something that can be administered only through daycare centers or rehab centers. But that isn't true. Even in our regular OPD practice, we can integrate rehab. We can customize it to the requirements of the patient, right? And another thing that I have personally been able to notice after I have moved into the private space is that most mental health professionals, most psychiatrists lack the confidence, or at least the younger ones, the young psychiatrists lack the confidence that we are able to make a difference to a patient's life outside of medications. So unless we believe that we will be able to make a difference, I don't think we'll be able to create any tangible results. So this is something that I think we have to focus within ourselves, to trust ourselves, right? So some of the tools that I have been able to use in my own practice, which I think is easily adaptable, is about, of course, psychoeducation being at the core of it, explaining to a patient that we may not be able to help them feel relieved of all the symptoms, but at the same time, we might be able to make them utilize whatever other positives they have in them to the best of their abilities, right? And another thing that we would be able to do for the patient in the earlier meetings would be about getting the family, friends, and other important stakeholders to understand that this is a journey. It will take its own times, and we need to work with uncertainties that come in the process. But just like managing diabetes or just like managing any other chronic illness, this is something that will happen with time, right? Luckily, now with the digital world, we have access to a lot of resources. I think, at least in urban settings, most people, even from lower socioeconomic strata, have a smartphone, the most basic model. So it's easier to get them to use apps or use content which is available online, such as maybe just using phone reminders, using alarm clocks, using simple stuff like this to just get them to come back to a routine. And of course, there are so many mental health apps now developed after COVID, which give free access to things like self-help and behavioral activation charts, etc. These are things that we should be able to use in our OPD practice for a functional recovery directive treatment. And another important and key area that I would say is that maybe our role would be just connecting people. And it may not go beyond that, but just getting people connected with each other is very relevant. And just to give you an example of this, last year I was introduced to a person who has schizophrenia from 10 years and who's in her 30s now and had to lose her job because of this. Otherwise, she was a teacher before that and very good in the science subjects, right? The only thing that I was able to do for her was connect her to someone who had information about online B.Ed courses. And from there on, she took it up, and now she's combining an online B.Ed course with a digital data entry course, and she's already employed part-time. And after a gap of 10 years, she's back to earning some amount of money, and maybe in a year, she'll get onto a full job. All I did was connect her, but I think that made a difference to the course of her life. And I think these are the small actions that would definitely make a difference in our patient's life. And to summarize this, I would say the last and one of the important things in private practice would be networking. We are likely to have, in urban settings, it's common to have other mental health professionals in your area. It's a great idea to network with them, see what are your strengths and what may not be your areas of expertise, and refer patients out to them in a collaborative way where you can work together with other professionals. This is something that I found very helpful in my own practice. And I'm sure that at least in areas in bigger cities, it's something that's very well possible, right? With this, I will be concluding my presentation. And I think we are also going to be opening the stage for any questions.
Thank you so much, Dr. Vandana, for that really great exposition on how we can make a difference and how we can go the extra in displaying our care and our efforts towards helping patients to function better, even with medication, something which I think is a big inequity in terms of training programs across the country. There are nearly 1,000 to 1,100 psychiatry trainees coming out now. In 10 years, India has tripled its output of psychiatry postgraduates. And in that, a lot of them don't get the exposure towards what you have mentioned. And that's something very useful, which even Dr. Jitendra pointed out, was that taking this up will also help you to learn and remain connected with those skills. So that's super. I'm so happy to see how all the three talks and from the panelists really connected and grew. It was just flowing with one after the other. So at this point of time, I see that we don't have any questions in the chat, but I do hope that we could have a small discussion on things, and then I'm going to ask that audience can now either. We have a question here. So I'm going to ask Dr. Vandana to just moderate the question and answers, and then after that, I'm going to suggest that we can also have a discussion. It's for you now to unmute yourself, and you can also ask your questions. Do raise your hand, and so that we can come to you based on an order, and we're not speaking over each other. That's the only thing. Right. Thank you so much.
Yeah. So I think the question is for Dr. Jakar from Dr. Shoaib Khan. He would like you to just repeat the names of the apps that you've been using.
Yeah. First of all, I think so to the whole of the platform that I was unable to share my slides. But I can tell you the name. In fact, I can share my slides with everyone. So I'll briefly, the major platform I think which basically worth enrolling yourself is, first is the Practo, second is Tata Health, third is DocPita, and fourth one is MFine. So you get huge chunk of your patients from this online platform. There are few platforms also, like one, like recently I came across is the DocSat. But the problem with that platform is that you also have to be very much worried about the telemedicine guidelines. So the majority of the patient which have been coming to the docs app is the sexual, basically who have the sexual related concerns. So in that, because I was not comfortable with the telemedicine guidelines, they have not told about anything. So I practically, I thought I'll refrain from those platforms. But they have good number of patients. In fact, 60 to 50 patients they give you over a period of day. So if you people are comfortable, that DocSapps is a good platform to think about. Apart from that, this other platform, I think so you will get fair amount of patients.
Yeah. There's also a question by Dr. Sachin, Dr. Vandana.
You know, if I missed it, just a minute. Dr. Sachin says, wonderful webinar, really helpful. I believe I missed a question then. It's not.
Yeah, I'm sorry. I think that was just a comment. Yes, sorry. I think there's lots of comments pouring in. I think Dr. Manjunath has also provided a comment about group practice. I'm just going to request him to unmute himself and tell us about a little bit about the group practice and how that can be facilitated. Dr. Manjunath? Okay, I think we'll have to come back to him. Dr. Manjunath, if you're able to hear us, please do unmute yourself and tell us about this group practice concept. It'll be great.
Sorry, Shraddha. I'm in an ICU. I'm seeing a patient. I can chat. I don't think I can answer the question.
Not a problem. Not a problem.
Yeah.
Anytime.
Sorry for that.
Not a problem. Yes. Please continue.
I would actually like to ask Dr. Sarin for some advice that would be helpful for all of us, I guess, for at least the young psychiatrists. So one of the things that has been an experience for me, and I guess for even others, would be that in urban settings, the number of dropouts is very high. And even if we seem to be putting in our best efforts, we wouldn't know the gap as to why we may have a higher attrition rate of patients, so to say. So is there any tips that you would be able to recommend to us on how we can work in improving our practice?
So, firstly, let me say, Vandana, that if I may, that I really liked what you said. And I think that makes complete and total sense, And I think that the three things to remember are, one, that what we think of as a rehabilitation actually starts from the beginning. That rehabilitation is not separate from any other treatment. That rehabilitation is not disorder specific. So somebody with an anxiety disorder as opposed to somebody with a profoundly disabling psychotic illness will need different sorts of thinking, but everybody in big or small ways will need it. And I think that's something that very often we don't recognize. The experience in practice has been, to my mind, is the longevity of follow-up. So there are people, I've been in practice for about 30 years now, and it seems It seems quite a really long time. But there are people that I've been seeing for 30 years. And there are people I've seen for actually more than 30 years, because these are people that I was seeing when I was working at the All India Institute prior to being in practice. And in many ways, my sense is that, what you bring to practice is your own persona, your own sense, and everybody will bring their own, their own ways of doing things. The one thing to guard against is being anxious. If you're anxious about why people are not recovering, then we get pushed into perhaps pushing medication faster and harder, which is a slippery slope. What we get anxious about is about practice not working. And then we might get pushed down the slippery slope of how should I say, of unethicality. And unethicality can also be laziness, that I don't think hard enough or long enough about what I should be doing and what the best way of doing this. So I think that over medication, I think that irrational drug prescribing, I think that not thinking enough about these things is both lazy and unethical. And I think that by doing this, I do both my client and even myself a very large disservice. I actually honestly believe that if all that you're going to do is sit there, listen gently, sensitively, and patiently, and offer the best advice, there is no way that practice is not going to work. There is no reason to be anxious. It will be like all endeavors in life. In some it will work tremendously well. In some people may not get better. Some people will get somewhat better. But that's pretty much true of all things in life. And unless I understand this and respect this and go with this, you're not going to become rich overnight. You're not going to become, people are not going to line up outside your clinic. There have been many months, weeks, months, years when I became really good at doing the crossword, because I was sitting and twiddling my thumbs in the clinic. Fortunately, I like reading, so I read a lot. So I didn't get too bored sitting there because there were no patients. It will happen, and it is fine. Things take time, and we have to be prepared for them to take time. If we try and push this too hard and too fast, we may not be doing ourselves and the clients and the practice service. So we have to be patient, but we have to be patient in all things in life. So there's no shortcut, but then there are no shortcuts in anything, I think. So it will take time, and we need to work hard at it, and it will happen. And there's no reason why, if I am doing it properly, that it will not work. and the bit about the developing networks, I think is also very vital. I think it's very important because that is exactly my experience. For many years, what the one thing that bothered me about practice was the lack of communication with peers and colleagues. And then, fortunately for me, I joined a hospital and I did develop. I mean, I happened to find an excellent set of people. It was brilliant. It was spectacular, and I think it worked very well for me. And I think the finding of other interests along with practice is perhaps as important as anything else. And I think that as we go along, I echo and I sort of reverberate so much with all of the things that you said. I learn enough. I mean, I learn as much and I grow in my practice, and I grow thanks to the learning from the patients. And in a sense, that is what makes the practice rewarding. So I think that perhaps if we do that, I see no reason why it should not work. But thank you for your presentation. I really enjoyed it.
Thank you. Thank you for your wise words also, Dr. Saran. I think it's very meaningful. Regarding the networking, something that I would like to share with everyone is when I moved into private practice, that was last year in Feb, right before COVID. Of course, one of the fears is that there's going to be so much competition, and in urban settings, I'm in Bangalore, so there's so many psychiatrists here. But I tried something that would have sounded very weird. I made it a point to contact all the psychiatrists in my area. And I just introduced myself and I just spoke to everybody. It created a really nice network for me. And so now if I get if I get a geriatric case, which I don't feel confident to handle, I just call up my colleague here who is quite senior to me, and she's very helpful. She guides me through, or I send them to her. And similarly, for psychologists and social workers, I've been able to create a good network in the last 1.5 years. And we do a lot of good collaborative work. So we talk back and forth for each case, and we let the patient know about how we jointly feel about it. Many of them are colleagues from NIMHANS. And it's something that I found very comforting and helpful. And I'm sure that for everyone else who will set out into private practice, this is going to be something that would be very helpful to you as well.
I think that's very
Yes, sir. Please go ahead, sir.
No, I was just saying, I think it's very important.
Yes, sir. I mean, that's very sagely wisdom that's been suggested here about networks and even within the discipline itself. One of the questions that I had, and when I've been discussing with some of my friends, is when they are in tier 2, tier 3 cities, it's very difficult to even get through non-psychiatry peers. And how do you discuss with them? And there are many times that the referrals seem inappropriate. And how does one give feedback while at the same time ensuring that the door is open? How does one comment about unethical practices by others, by peers, by non-psychiatry colleagues? In terms of, there are many a physician who would put someone on 2.5 milligrams of Serenase and say that, this is your condition of bipolar mania will get better in some time. And then, they would just send a referral to a psychiatrist like me and ask us to kind of, why don't you just opine on the treatment and change and all of that, while at the same time keeping the patient with them. So how does one respond to such things? How does one handle this? In not just the ethical part of it, but also keeping one's interest and the long-term care of the patient in mind. So, and I thought this is something I heard from some of my colleagues, and this was a query that I just wanted to put up here.
So, it's like it's like walking in the real world. There will be difficulties, there will be places of light, there will be places of shadow, there will be roads which wind. And I guess all of us will have to find our ways and our, how should I say, our moral compasses, more importantly than anything else. All I can say is my experience, and my experience is actually, how should I say, boringly simple, which is that I think that the only way to do this is with civility, with humility, and with truth. There is no alternative. So there will be situations in which you will get offered, cuts from laboratories. Nobody's forcing anybody to take those cuts. They're not being offered to us at gunpoint. They are saying that, look, if you want this, you can take it. If you take it, then you're compromising yourself. If you don't take it, then your earning may be a little bit less than it would be. You might take a little longer. You might be doing the crossword a little longer, but you'll get better at the crossword. You will read more books. It may take a little bit more time. But that has nothing to do with the practice of psychiatry. That has to do with the living of life. And that has to do with what I think my tenet is, where I think my moral compass is. And which is why I think that for all of us, what is important is of course that we need to figure out what the dose of fluoxetine is and when to combine clomipramine with fluoxetine, or when to add risperidone, or how often to get the TSH done if a person is on lithium. All of this is mandatory, but this is a given. More importantly, be over and above and beyond this, I have to figure out where my moral compass is. And that is true for the living of life. And that is true for the practice. That is true in what that depends. And that will depend how I communicate with my client. It may sometimes mean that I will tell somebody that, look, I understand that you are having a sleep difficulty, but I think that you have to work harder at maybe putting in an exercise regimen. And I'm not going to prescribe a benzodiazepine or zolpidem for you, because I think that, this is perhaps the right way to go. It may not be the easier way to go, but this is the right way to go. In fact, I think that much of the challenges in practice, and this is nothing to do with private practice, it happens as much in academic hospitals. I think benzodiazepines get grossly overprescribed. I think the sedatives get grossly overprescribed. And I think that's people being lazy. I think they're not working hard enough to try and convince the person or work with the person to help him to find alternative ways in which sleep can be regulated. So this has to do in larger ways with how I conceive of a personal ethic, and in what way that personal ethic is manifested as a work ethic and a professional ethic. And that is a different conversation. That will not make my practice any easier. So if somebody sends me a referral, and they've said, and they've put like you said, 2.5 milligram of haloperidol, I will tell them that, look, my sense is that maybe we should be changing this, and this is what I would suggest, and maybe regular follow-up is a good idea, and then ultimately, in life, in the real world, I can help all those people who are willing to work towards being helped. So I will explain this to my colleague, and I will explain this to the client, and then it's up to them to figure out what it is that they want. It's not income. So there's also a big thing about doctors playing God. That I think that I have to solve the problems of the world. And my sense is, no, I don't actually have to solve the problems of the world. I have to do a lot. I think that for a doctor, for a good doctor, being a good citizen, being a responsible citizen is very important. But at the same time, I have to know my limitations. I have to know what it is that I can do, and I have to do what I can within those limitations. And those limitations are dependent upon me. And so I can choose to work with community mental health. And I think that working with community mental health, working with the homeless people with mental illness is a very, very large thing. And I think that is something that all of us perhaps should be figuring out, that apart from our practice, how is it that we can contribute to social iniquity, not to contribute to social iniquity, but how do we deal with social iniquity, counter social iniquity, and we have to figure out that as well. So all of that is certainly incumbent upon me, but at the same time, I have to figure out what the right ways of doing this are.
Yes. And thank you, sir. That's really insightful. And I mean, yes, those answers, in a way, they seem somewhere, yes, that's how I should be going about it, and going, in that direction. But then, as you rightly pointed out, doing the right way and the easy way may not always be the same. And it's better to always choose the right way rather than the easy way out many times. I mean, because then that makes a lot of things easier later on. Yes. I think we've had a wonderful evening. We've had a wonderful discussion, lovely talks, and very pertinent, lucid explanations on these topics, and expositions on how best to work with platforms and what challenges are faced when starting out in private practice. Both young psychiatrists present here today had started off during the COVID times itself in their private practice, and they have shared a lot of insights. And we also heard about the importance of truth and how truth makes it more bearable, just that much more bearable. And working towards functional recovery can just be that extra mile that can make that difference for the patient as well. In all of this, I also hear a tone that, yes, protectionism and paternalism should be on the way out in our practice, while I think that's one of the serious contributors to our anxiety. Our responsibility is there in helping the patient, and the patient, as we help in the best ways possible, they will get helped. And it is less of a certainty, but also not an impossibility. So in that way, I think we can take hope. And I really enjoyed listening to all of you today. Thank you so much for being with us here, Dr. Sareen, Dr. Jakar, and Dr. Vandana Shetty. Thank you so much for your insights. Thank you so much for talking about what were the personal insights that you had, and sharing these nuggets with everybody here. I really enjoy knowing that there are so many people listening to this, and they've stayed on from the word go in the meeting. And I believe that it's been a great blessing for each one present here. Not so much a captive audience from IAPT, but more a captive audience to each of the panelists who've been talking and sharing from their lives and their experience and journey through private psychiatry. Thank you so much to each of you present here. You make it all the more meaningful for us to do more events like this and for us to share more learnings. We'd really love for you to connect with us over Facebook or any of the social media handles, and you would be able to follow us and find out about the events. In case you're an early career psychiatrist or a trainee and you're not yet part of the IAPT, we welcome you. Come join us, and let's make it better for all the psychiatry trainees and ACPs in India. And that's going to be a fantastic thing. Let's see it blossom into bigger initiatives and bigger events like this. Finally, and most importantly, I would also like to thank our technical team, which has been ably supporting us. That's Drs. Prabhu Jadhav and Dr. Vishu Kumar, who've been helping us through the meeting and handling everything at the back end so that we had a smooth going on. Thank you so much to the IAPT team and all the support. Thank you so much for all the committee members and all the people who've joined and all the IAPT members who've joined in. Thank you for making it possible. I'd like to close here and tell you that we are also going to have a quiz coming up, a national quiz for all the IAPT defined early career psychiatrists and trainees. Very soon you'll hear about that. It's going to be an exciting thing with lots of cash awards. Do stay tuned, do connect with us on the links which are provided here. Thank you so much. Have a good night and a very happy World Mental Health Day in advance. Bye-bye.
Thank you.